sharing my slides and just to kind of introduce what tonight's all about. So the idea of tonight is to go through some relevant guidelines and reports and kind of topical documents which might feasibly come up in the exam, or equally you might be able to refer to and might be the kind of things that will make the examiners stop listening and just say, okay, this person's passed, no trouble. There are obviously, an infinite number of these. So I've tried to group them together and do them in some kind of order. But the slides, I'll just go on to the next slide here. The slides will be made available after the talk. And there's also a document that we've prepared that's got a link to all of the source documents. So if you want to go and look at any of the guidelines or any of the documents later, there's links to them all in there. We'll basically go until about 7:45 and see how much of it we get through. As I say, I've kind of tried to group them together, but there will always be more than we can get through. But we'll send the source material around. The main aim is hopefully that I've kind of gone through and brought out the main points from these guidelines to save you having to go and look at them. And if you can, just take away some kind of useful tidbits of information. So without further ado, this is what we're going to, this is everything that's in here. And as I say, we'll get through as much as we can. And anything else you can look through in your own time, it'll be shared around. So we're going to start with some Airway guidelines and documents, because everything has to start with Airway, obviously. And the ones that I'm going to focus on are ones from the Difficult Airway Society. I'm not going to go through the unanticipated difficult intubation guidelines, because those are, bread and butter standard things. I'm going to go through these other ones because I think they are potentially useful. And I mean, some of these didn't exist when I did my exam, so I think they're quite useful. So the first one we're going to look at is the awake tracheal intubation guideline, which includes awake fiber optic and also awake video laryngoscopy. But predominantly I'm going to talk about awake fiber optic. One of the benefits I think of this document is that certainly when I did the exam, I didn't really have my own recipe or technique for the procedure, because every time I'd done it, I'd probably done it with a different consultant who had a slightly different technique. And if you haven't seen it, what's nice about this guideline is that it gives you quite a straightforward and simple recipe and approach. So if you're asked how you'd go about doing an awake fiber optic, I think it's a useful thing to hang your hat on. It gives you this overall structure, and we're always talking about structure and everything, aren't we, and categorizing everything. And it has this stop mnemonic breaking down the key components of the procedure. The S is in lowercase because they stress that the sedation aspect is optional, and particularly in more high-risk patients or more unstable patients, the sedation is an optional element you can leave out if clinically appropriate. And then it goes through the topicalization, the oxygenation throughout the procedure, and how you actually perform intubation. But I think the most useful things are the kind of clinical pearls in it. So they mention contraindications. So the relative ones are things you might expect. And the only absolute contraindication in their opinion is a patient who refuses to have it done. So even with local anesthetic allergy, they say that's still only a relative contraindication. And then they provide these diagrams, which kind of form the basis of what gives you the nice structure that you can refer to. So I'll just go through a bit of the key points that are in this. That, as I say, this will all be sent around, so you can have a look at it later. But I think they've displayed this in a slightly strange way. But starting with the oxygenation up here, they recommend using high flow, just because it's, it gives you a nice little safety margin. It's more widely available now. So I think it's reasonable to say that you would put patients on high flow to do the procedure. It then also gives you an idea of how to run your sedation. So it even gives you a dose range there for your remifentanil. But the main thing I thought was helpful about this was the topicalized box, because there's so many different ways to do this. Everyone has their own preferred thing with, lidocaine gel, nasal airways, and all the rest of it. But this one is very straightforward and is just based predominantly just on the lidocaine 10% spray, plus minus cofenilcaine if you're going through the nose. So I think this allows you to just simplify what you would say that you would do. And it basically rely almost completely on the lidocaine 10% spray in the mouth, base of the tongue. 20 to 30 sprays is fine for most people, with one spray being 10 milligrams. And if you're going through the nose, put some cofenilcaine in the nose. And the other nice little bit that shows that you know what you're talking about is to test your topicalization before you start the procedure, either using a soft suction catheter or using a Yanker sucker. And it only mentions things like spray as you go and MAD devices as kind of rescue techniques if you haven't got enough topicalization. So what I liked about this is that, you can just say, right, I will use this lidocaine 10% spray and I'll put some cofenilcaine in the nose. Keeps it simple. And then it's just got kind of tips in the guideline about how to actually perform it, things about the ergonomics and how you sit up the room. But in general, mostly we're talking about fiber optic, and it even says, do it from the front, set up your tube with the bevel facing posteriorly so that it goes through the cords more easily and is less likely to abut. Little things like this in this guideline are nice little things that you can refer to if you're asked to describe the procedure. And then finally, before you put them to sleep at the end, they describe this 2-point check of tracheal tube placement, capnography, as with every other tube, and then visualization, either of the cord in the trachea, of the tube in the trachea, if you've done fiber optic, or if you've done video laryngoscopy, of the cord going through the tube, tube going through the cords. It then gives you another little algorithm on the same layout, just if you have problems with any of those steps, what you can do. So a reminder that the maximum dose when we're topicalizing with lidocaine is 9 milligrams per kilogram. If you're sedate, the reason they recommend remifentanil plus minus midazolam is that you can reverse it easily if you need to. And then things like suction to clear secretions, 3+1 attempts. Don't be afraid to call for help. And finally, it gives you an algorithm of what to do if it hasn't worked. And although you're under pressure to answer these kinds of scenarios, the main point of this is to stop and say, right, do we need to carry on with this, or can we bail out, basically, which is the same in the difficult intubation algorithm. But if you do end up progressing because you need to manage the airway now, you progress to a front of neck approach, which is, in this case, might be ENT more than an emergency front of neck. But ultimately, if all of this fails, they direct you to the regular intubation guideline, which seems a bit strange given that you're doing an awake intubation in the first place. But that's where it ends up. But I think the main thing that I think is useful about this for the exam is, if you haven't got your own recipe and technique, there is something there you can talk through, you can refer to, that, so you know that you've got a safe approach to this technique. And the main point of the guideline is to kind of lower people's threshold for doing these kind of intubations. So that's the key points from the awake intubation guideline. The next one I'm going to mention is just the extubation guideline. It's an older document that's been around the similar kind of time as the difficult intubation guidelines. And there was, I think when I did the written, there was a question on a difficult extubation and what your plan would be. And again, it can very easily come up in a Viva situation, particularly if you're starting with a difficult airway, the question of what you're going to do when you get to the end. And the main things that, if you haven't seen these, to highlight from this, they give you algorithms that are structured in the same way as the difficult intubation ones. And the useful things I think in here are risk factors to look out for, that might predict that it's going to be difficult. Things that you can try and optimize prior to extubation. And then it's this main risk stratification section where we're saying, well, is this a normal extubation, or is this an at-risk extubation, either because it's going to be difficult to get the tube back if it comes out and we get into trouble? Is this patient, or we're struggling to oxygenate them as they are? So if we took the tube out, we'd have potentially more difficulties. Or are there other risk factors, things like, airway swelling? And it just directs you down one of these two algorithms, and is a useful way to structure your thinking. The low risk algorithm is just, this is just, routine and extubation. I don't think there's anything in the low risk algorithm that would come as a surprise to anybody. Obviously the two options provided a deep and awake extubation, but that's all the kind of standard pathway. It's more the at-risk algorithm that I think is useful and more likely to be something that you might end up talking about. And it lays out for you quite nicely what your options are based on whether or not you want to leave the tube in or you want to take it out. So your options, if you're going to leave it in, are obviously to say, okay, we'll extubate at a later date and the patient goes off to intensive care. Or depending on the context, you might convert straight to tracheostomy. But then there's this kind of, yes, it's a high risk extubation, but yes, we're going to take the tube out. Option one obviously is the same as it is normally, take the tube out awake. But then this is what the question I had was about these advanced techniques that you can do to facilitate getting the tube out. And it was about LNA exchange that you may have seen as this previous question. And it was about, how you use that to facilitate getting around someone who's potentially difficult. So effectively, it's like a deep extubation, but you put an LMA in at the time that you take the tube out. So you essentially do a deep extubation, but still have some airway protection. But then the rationale is that there's less likely to be coughing and things later on. Similarly, with a remifentanil extubation, taking the tube out with some remifentanil on board is thought to smooth things, reduce the risk of coughing, particularly useful at the end of surgeries where you really want to avoid coughing for surgical hemostasis and similar reasons. Or the third one they recommend is an airway exchange catheter, by which they mean leaving an airway exchange catheter in the airway, which is surprisingly well tolerated, and is another one of the advanced techniques available. So this is just to give you an idea of what the options are if you have a case like this and it comes to them saying, are you going to take the tube out at the end? This shows them that you've got something you can structure your thinking around, and you're aware of some of the potential options, particularly if you're going to take the tube out using one of these advanced techniques. And then the last DAS guideline that I'm going to talk about is a very new one, just came out about a month ago, I think, which is about hematoma after thyroid surgery. The guideline is focused quite specifically on post-thyroid patients, although it does relate to any kind of after airway surgery difficulties. But this is a fairly classic exam scenario, and if you can refer to this and use this to guide your thinking, then I think you're going to be able to give a very, very slick and considered answer. So it's essentially in the situation of a patient in recovery after having thyroid surgery who's potentially developing airway compromise as a result of hematoma. And it starts by giving you some ideas of some of the concerning signs that you might be looking for in these patients, and recommends that these kinds of things are a part of the routine monitoring for this patient. Apart from the early warning score, it's things that we would be looking for anyway as potential airway risks. But it's about putting this in the hands of recovery and nursing staff so that it can be detected earlier and escalated appropriately. And then if these kinds of problems are detected, you're going to need some kit with you. So it recommends that all these patients have an emergency box at the bedside. which is with them from recovery all the way through, which contains these various bits of kit, essentially what you would need to open the neck quickly. And it also recommends, which is quite a new recommendation, that there is emergency front of neck access kit available on all wards where these patients are looked after, so on the surgical wards, basically, just in case you get into this kind of difficulty. And then it gives you this, again, an algorithm to deal with these patients. So this is kind of pre-anesthetic involvement. It's where the patient's being monitored and they're picking up these concerning signs. So it gives initial kind of conservative measures. So sit the patient up, apply oxygen, as with everything. And the first port of call that they ask for is a surgeon. So this is all before it's got to the point that it's an airway emergency that an anaesthetist is going to be called to. And it gives you some kind of basic medical measures that you can put in place, like giving DEX, considering TXA, doing an endoscopy. And it highlights again these signs of airway compromise that we would be familiar with, but this is useful for people who aren't so used to dealing with airways. If the signs of airway compromise are detected, then this is where it gets more anesthetically emergent. But I think the important thing from this guideline to note is that evacuating the hematoma comes before definitive control of the airway. So it's very much get the hematoma evacuated and resolved, and then have a look at the state of the airway after that, rather than step one, rush to somewhere else to control the airway and then see about surgical control. This very much says get the hematoma out first, and we'll come on to it gives you an algorithm for that as well. But do that first, assuming there's skill mix available to do that. And then if the airway is still a problem, then move on to control the airway using standard, difficult intubation guidelines. And with any predicted difficult intubation, it makes these recommendations about video laryngoscopy. Most experienced operator has first attempt. And like anything else, emergency front of neck access is the get out of jail free card. And on the evacuating hematoma, you wouldn't be required to have too much knowledge of what exactly that involves, but this guideline provides more useful information than I personally knew. And this is its kind of approach to doing that. It's got this dodgy picture of a mobile phone for some reason. But it gives you this scoop mnemonic, just a reminder that it starts with skin exposure. So whatever there is there, if it's steri-strips, if it's staples, get them out of the way. Then cutting sutures across the wound. Then it's 2 stages of opening. So I think this is the bit that shows you have an understanding of what you're dealing with. Firstly, opening the skin, and then secondly, opening the muscles, so the deeper layer, in order to then expose the trachea. And then hematoma comes out, everyone rejoices, cover with a pack. And then they make the point that you then need an onward plan for definitive control and what you're going to do, but also you need to think about how the patient's going to be looked after. And it recommends things like clinical psychology input, because you've got an awake patient with some degree of awareness of what's going on, who's having their neck opened because they can't breathe. So it does make that explicit recommendation to consider that. So another thing worth, it's not just the staff who'll be affected by it, there's obviously the patient as well. So those are the kind of recent and I think relevant airway guidelines, apart from the obvious difficult intubation one, which I think can come up. The next 2 I'm just going to briefly cover, because these, in some form, these have been around for a while, but these are sort of just general things that apply to most anesthetics, which are the standards of monitoring guidance and the TIVA guideline. So the standards of monitoring guidance, this has been around for a long time, but it has been updated this year. And there have been some changes made from the previous version. The main changes are in these sections. So there's new recommendations about capnography, about the use of neuromuscular blockers, with regards to how you monitor it, and also the implications with TIVA, and then just other modalities of monitoring, which are now recommended should be available. And I think this is the main thing that's got, well, it's changed, it's got stronger in the wording. The minimum monitoring for a GA hasn't changed. We're all used to kind of rolling out the AGBI minimum monitoring spiel. But what has been added and strengthened is that all of this should be continued on leaving theatre through to transfer to recovery. And if you've got an airway still in place, so if you go to recovery with an LMA, the capnography should be continued until the airway is out and the patient's awake effectively. And that is for most people, that is where the reality of clinical practice diverges from what the guidelines suggest. But I think it's now effectively become the exam answer, is that capnography is maintained through that transfer and until an airway is removed. Whether that's the reality of what we see on the ground is another question. But that is now, none of this is mandatory, but that is now the guidance from the association. There also is some more detail on monitoring for patients having regional anesthetics. The minimum monitoring is unchanged, and as you might expect, but they do recommend that it should be continued for at least half an hour after a block is done. And they give specific guidance on the case where patients had a block and then you as the anaesthetist are leaving. So maybe they're having awake surgery and the anesthetic assistant is going to stay with the patient. The specific guidance there is that the anaesthetist should be immediately available for the first 15 minutes after the block. And then for the rest of the duration of the case, essentially, should be able to attend within 2 minutes. In the case of procedural sedation, this wasn't specifically drawn out as its own section in the previous version of the guideline. The minimum monitoring is essentially the same as the GA, to the extent that capnography is needed if you no longer have verbal response. So kind of once you're into deep sedation, capnography is recommended in the guideline. And then transfer is another new bit in this guideline. So they formalize the fact that any patient being transferred should have monitoring equivalent to what they would have if they were in the operating theatre. So this harks back to what we're saying about GA patients. When you're transferred to recovery or to the PACU, you should maintain all of that monitoring continuously. So you shouldn't be taking the monitoring off. And you should have the capnography. Obviously, there's kind of this transfer and this transfer. So this covers all intra-hospital transfers. So patients going for scans and things. In which case, you'd expect to have this, but it's more that kind of operating theatre to PACU again that they've stressed. As long as there's an airway in place or a patient is deeply sedated, that should all be continued. The other things that are sort of newer in this guideline is that it's now recommended that quantitative neuromuscular monitoring is used whenever any neuromuscular blocker is administered. So it's gone beyond just a standard trainer 4 monitor, qualitative observational monitoring. It is now recommended that that is quantitative, that it's started before any neuromuscular blockers are given, and that monitoring is continued until the monitor has told you that the patient is fully reversed, i.e. the trainer 4 ratio is greater than 0.9. So that is now kind of the standard of practice. Again, it's very dependent on what equipment you have available. But the sort of exam answer now is this, whenever someone has a neuromuscular blocker, they should have the quantitative monitoring, and it should be continued until the monitor says that the patient's reversed. Linked to this is the use of neuromuscular blockers with TIVA. So it's mentioned in the TIVA guidance, and it's been mentioned in things about awareness, but it's now in the monitoring standards of monitoring guidance. Whenever a patient has a neuromuscular blocker and is having TIVA, processed EEG monitoring should be used. It was, as I say, it was kind of alluded to in other documents and in other guidelines already, but it is now in there officially. Should be started before induction and continued until you've confirmed with your quantitative neuromuscular monitoring that the patient is no longer paralyzed. They should have depth of anesthesia monitoring with processed EEG all the way through that if they're having TIVA. And then there are some other types of monitoring that it makes recommendations about, and how available they should be. So you should be able to immediately get access to a blood glucose and ketone meter, and we should be monitoring the blood glucose of diabetic patients at least hourly, more frequently in certain situations, but at least hourly. And we should be able to check the ketones if we need to. And the other monitors that you should have access to, they don't have to be immediately available, but you should also have access to blood gas monitoring, point of care hemoglobin monitoring, so HemoQ or similar, or through a blood gas. And flexible bronchoscopy should be available anywhere that anesthesia is administered. Again, that might not be entirely feasible in some locations, but that is what should be available, according to the new version of the guideline. And the other thing the new guidance does is makes recommendations for departments, essentially kind of checklists of all the things that they should have to see how they comply. So it kind of helps as an audit tool as well. So that's the new monitoring guideline, and particularly focused on the changes. The other one in this section is about TIVA, and the formal TIVA guideline from the Association and Society of Intravenous Anesthesia. This just has some general kind of best practice points that I think most people have accepted anyway, but they are now in this guideline. The first is that if you're using propofol TIVA, you should use a TCI pump and model rather than a manual infusion or a mils per hour type infusion. I think that's quite widely accepted now, and the pumps are quite widely available. And the good practice recommendation is that the pump isn't programmed until the syringe is inserted into the pump, just to try and prevent you programming the REMI pump for the propofol, or putting REMI in and trying to run it on a propofol model. And as per the monitoring guideline, they make the point about the use of depth of anesthesia monitoring with neuromuscular blockade. And then in terms of practicalities, there are specific qualities, and this is comes under the kind of equipment heading as well. Specific qualities that a TIVA infusion set should have. And essentially they say you shouldn't be using a normal infusion set for TIVA. You should be using a specific set which has Luer lock on the syringe end and the patient end, anti-siphon valves on any drug lines to stop additional drug being drawn through, and an anti-reflux valve on any fluid line to prevent drug going back up the fluid line, essentially. And wherever possible or practical, the cannula should be visible and should be regularly checked, but it does, it accepts that that's not always possible depending on the particular clinical situation. There's a lot more in that guideline, but I think these are just kind of the key good practice points and things that you can refer to as a way that you make sure that TIVA is safe for patients, and things like the risk of awareness and things. You've taken all the steps you can to try and prevent that. So the next section is guidelines focused on specific groups of patients, which can come up as short or long case scenarios. And these are just those in which there are specific guidelines. And, I certainly had some practice instances where the person turned around and said, "Are you aware of any guidelines that relate to this?" And I usually wasn't, but these are some that kind of give us guidance in these particular situations. Again, it's usually just a couple of key points I've drawn out from wider documents. As I say, the links to all of them will be provided if you want to go and look at the rest of the detail. The first one is the Bariatric Society of Obesity and Bariatric Anesthesia, the SOBA guidance, which was updated last year. It's been around for a while. There's a full guideline, and then there's this one-page summary. And this is taken from that and just provides the kind of headline things that you can reel off that you would do if faced with an obese patient or a patient having bariatric surgery. Some of which is around practicalities and equipment, some of which is around the actual anesthetic technique. But it just gives you some useful, a useful list to reel off. It's one of those kind of standard questions. How would you anesthetize a patient with a BMI 40 or 50 or what have you? And it also, on this one-page guideline, gives you, it talks about different ways to calculate body weights. There's a little cheat sheet, and it tells you which drugs are dosed according to total body weight and which drugs you should really be dosing based on reduced body weights. I think the useful ones to point out are things like the neuromuscular blockers, the antibiotics, particularly things like gentamicin, and there's a kind of broader discussion about how you program your propofol pump for TIVA, and the SOBA recommendation is that you use this adjusted body weight, which is the ideal body weight plus 40% of the patient's excess body weight. And just for kind of a practical tip more than an exam tip, they've now produced an app as well, which some of you probably got already, but you enter the patient's height and weight and sex, and it gives you all of these body weights and tells you how to dose each of your individual drugs. So that's just saves you doing the calculations yourself, and is a useful kind of on the job thing. But yeah, the one page SOBA guideline is a useful aid memoir for the obese patient question. Then there's been several guidelines about diabetic patients. There was an association one some years ago. This is the most recent one, which is from the Center for Perioperative Care, and it's multidisciplinary with medics and surgeons as well. And again, it's a big document that I'm not going to go through all of, but I just wanted to draw out a couple of points. The first is around what's defined as poor control. So for the sake of this guideline, they define it as an HbA1c more than 69 as poor control, which would warrant referral to to diabetic specialist nurse or diabetic team. And they also point out that any patient with a continuous glucose infusion device should have specialist team input as well, continuous subcut insulin infusion. When the patients actually come to theatre, this is similar to the monitoring guideline, but just to stress, we should be checking blood sugar before we start, then every hour for patients who are on insulin, or every 2 hours for patients who aren't insulin controlled. And we should be targeting a glucose in the range of 6 to 12 in theatre for these patients who don't need to be, overly stringent. It makes recommendations about who should get a variable rate intravenous insulin infusion, which is essentially most emergency surgery, prolonged fasting, or type 1 diabetics who haven't had any of their background insulin. And it just makes the point that whilst on an infusion, patients should continue to have their long-acting insulin at 80% of their regular dose. which often gets forgotten and left off. And it just makes this recommendation, which keeps coming up in guidelines, about this ideal fluid to run with the infusions, which often is not actually available in clinical practice. But the guidelines all say half normal saline in dextrose with added potassium. But the main point is that whatever they're having, they have to keep having some substrate. So they have to keep having some glucose, as long as they're having insulin, to prevent hypoglycemia. It also contains kind of quick reference guidance for treatment of hypo and hyperglycemia, defining hypo as less than 4 and giving a standard treatment of 150 to 200 mils of 10% glucose if you deal intravenously. And for hyperglycemia, it gives you guidance on how much rapidly acting insulin to give in order to bring it under control. And the final two things that are in there are guidance points for those patients with the continuous subcut insulin devices. They should have their sugar checked more frequently. In a similar way to other implanted devices, keep it away from diathermy. Make sure that you can see where the cannula is going into the skin. And if the sugar is persistently high, then consider the pump to have failed, take it out, and start an insulin infusion. But again, you would be talking about having input from specialist teams and so on. And then the last thing that is in there, which I'm not going to go through in detail, is guidance about what to do with oral medications. The part of this that's been of interest most recently is the flozins, the SGLT2 inhibitors, which have been associated with the development of DKA, and they are the only one that needs to be omitted the day before surgery because of that risk. So that's just a relatively newly identified risk. Just want to draw out from that. The rest of it, it's all, it's very dependent on the timing of surgery and everything, but certainly with the flozins, kind of newly exercised caution. So that's the diabetic guideline. There's one about looking after patients with dementia. Now, much of this is about kind of general points for what's good for, all elderly patients, but dementia patients and other patients with additional needs, making sure that we involve carers and relatives where we can, trying to minimize disturbances. But the things I wanted to draw your attention to in this guideline are about drug interactions, particularly the cholinesterase inhibitors that are used as dementia treatments. They, through their action increasing acetylcholine, have impacts upon neuromuscular blockers. So you might need increased doses of non-depolarizing blockers, or you might avoid using them altogether. And helpfully, it says decisions on whether to stop or change doses should be made on an individual basis. But it does have several tables in, including this one, which just gives you specific guidance on specific drugs, and also gives you guidance about what to do for neuromuscular blockade. So one worth looking at. And then these are just the kind of standard, try not to disorient people, keep them oriented to time, person, place as best you can. And as with most elderly patients, try and avoid these centrally acting drugs because of their side effects. The last one I'll just quickly mention before wrapping up, and as I say, the rest of it will be available, is patients who are on steroids. The main point I wanted to draw out from this is that patients who are at risk of adrenal suppression due to long-term steroids, all you need to be taking is the equivalent of 5 milligrams of prednisolone for a month, and you are at risk of suppression and hypotension and Addisonian crisis type picture. So it doesn't need to be a particularly high dose. And they say if in doubt whether patients might be suppressed or not, give additional steroids. And the thing that's useful in here is it tells you in general what to give. So it gives this kind of base idea of giving 100 milligrams of hydrocortisone at the start and making sure that they are having additional steroid replacement until they can take it orally. But it does just make an important distinction between patients who are potentially suppressed because they're taking steroids versus patients who actually have primary or secondary adrenal insufficiency. And the main difference, and the thing I just wanted to highlight, was that for those patients in whom they're taking steroids, dexamethasone at useful anesthetic doses provides sufficient steroid cover for 24 hours at a dose of 6 to 8 milligrams, because that's equivalent to 600 to 800 milligrams of hydrocortisone. But because it doesn't have any mineralocorticoid action, for patients who actually have adrenal insufficiency due to, for example, Addison's, which is the next table, that is not an option, as that won't provide sufficient cover. So that's where this regimen of 100 milligrams of hydrocortisone at the start, followed by either a continuous infusion of 200 milligrams in 24 hours or 50 milligrams every 6 hours, is required, because the dexamethasone won't provide everything that they need. I'm going to stop there, because I could go on for much longer talking through these various things, but those are the main ones I wanted to draw your attention to tonight. We'll share the slides with you and also the document that's got links to all the other recent and relevant guidelines, so you can go through the rest of them in your own time.
I've got all those, so please just email if you'd like those. That's not a problem at all. I think the one thing I just think, Rich, firstly, thank you so much. That's really, really helpful and really kind of you to put that all together. It's an awful lot of work for you to have done. The thing I just say is, which is slightly goes in hand with recent guidelines, is that if you're going to mention recent guidelines, which is fantastic if you can get that into the memory banks, just be aware that some examiners might not be fully aware of those guidelines. So it's worth, rather than having a fight with the examiner in the SOE, which never goes down particularly well, just make sure that you reference the fact that it's a new guideline, and this is something that you've read relatively recently. I think that's the only thing, because you do hear some stories where people have a bit of a Barney halfway through, which doesn't go down that well. Anyway, Rich, thank you so much for your time and efforts. That's really, really kind of you. Guys, let us know. The other thing I just say is we're going to put a QR code up, not tonight because I haven't done it yet, but I will do it probably tomorrow night and maybe Friday night, where we'd really, really appreciate your feedback, because if we're going to run these again, we just want to kind of work on what's good and what's bad, and if there's any areas that would be useful for you. So that will be coming up. So if you could give a few minutes when that comes up in the next couple of nights, that'd be fantastic if you're going to join us. Other than that, we will hopefully see you for obstetrics tomorrow night. Thank you very much for your help. Sorry for attending this tonight, and hopefully see you soon. Rich, thanks very much indeed. See you later, guys.